couple of snafus getting started. Go ahead and begin. My name is Madeline Parmley, and I am the Trauma Program Coordinator for Oregon Health Authority EMS Program, as we're now known. Calling this meeting to order. So at this time, I'm going to introduce our designated leader. This was assigned by the Stella.
Just keep on talking, come on.
This was assigned by the Thompson Local Emergencies Advisory Committee to have one of the liaisons be the lead for this committee. And so they are going to help us stay on track. We are not calling them chairs, we are calling them leaders for the sake of these meetings, and that is Jeremy Biller. I believe I am turning it over to you, Jeremy.
Awesome. What do I do, Stella?
Move forward with the meeting, sir.
And go through member roll call.
Yep, it is all you now.
Yeah.
Congratulations.
Congratulations, Jeremy.
Super excited. Bear with me as I fumble through this first one as we get a little get more comfortable with these meetings as they happen. So I guess we'll do the member roll call. Our trauma medical director, Alexis Morin.
Present.
Trauma surgeon, Megan Lundberg. Pediatrician physician, Stephen McGoffey. Is that right? Looks like I saw Willie Foster on earlier, emergency physician.
Yeah, I'm here.
Chris Polson, EMS physician supervisor.
I'm here and almost there.
We do have an open spot for a rehab specialist. We'll get to that coming up a little bit later. We can kind of define that position a little bit more. Then we have a patient advocate, educator, injury prevention coordinator, Matt Edinger, and he is floating to Colorado, so I know he's not here. Then I'm here. And Sarah Daniels.
Present.
EMS provider, Victor Walco.
Present.
And then our hospital administrator, Anna LaRosa.
Present.
Awesome. Looks like we're only missing 2 people. Let me get back to my agenda. I believe this is where someone is going to discuss. Oh.
I think we just did that.
Poof. I think we kind of did that already, didn't we? Or do we want other people to introduce themselves?
We do have Dr. Maybe if we go around and talk about it quickly, since we have time, your name, what facility you're here from, or organization. And I do know that we have Dr. Polson, who's on his way here, who's one of our new members to the committee.
Sure.
Sarah?
Did you want me to? Oh, I'm sorry. Did you want me to just introduce my basic background? Is that what you're asking?
Yes.
Okay, sure. So I'm an emergency medicine physician. I work primarily at Sacred Heart River Bend and some other places. I also work on the coast, some at a couple of different facilities. I'm a supervising physician, medical director for a number of agencies: Eugene Springfield Fire, Western Lane Fire, Reach Air Medical for critical care air medical things. So, and I've been in Oregon and involved in these EMS medical direction since 2010 in various ways. hopefully that's a little summary. And I've been part of the ATAB for a number of years, et cetera.
Sounds great. Well, welcome.
Thank you.
So do we want to start with the folks that are in the room over there with you, Madeline, to give introductions, and then we can pop around on the computer?
Sure.
Want me to start? Sure. I'm Sarah Daniels. I am the trauma program manager at Salem Hospital from ATAB 2. I've been in my role, just hit my 1-year mark. Previous to that, I worked for 4 years as our stroke coordinator at the hospital. And prior to that, about 9 years in our emergency department as a staff nurse and a trauma nurse.
I'm Alexis Moore, and I'm also at Salem Health. I am the associate trauma medical director, and I've been there about 8 years. I am also the state chair for the Committee on Trauma, and that's about it.
I'm Victor Walco. I'm the Director of Business for LifeFlight, and my time there at LifeFlight, almost 11 years now, mostly has been focused on external process with our hospital and EMS partners. It's very interesting to be able to attend all of the ATABs across the state of Oregon, as well as in the other states, and draw similarities and what works and what doesn't work so well, and bring that to the different communities that we participate in.
My name is Albert Ramon. I'm the research analyst for the EMS program here, working in the data team. And I primarily focus on the trauma registry.
I'm Anna LaRosa. I'm the Chief Nursing Officer for St. Alphonsus in Ontario, Oregon. Woohoo! In a previous life, I've been there for about 5 years in that role. Prior to that, I was the emergency services and trauma educator for the system. And then my background is ER and ICU nursing, as well as I've been a paramedic for about 25 years, just in case the nursing thing doesn't work out. Yeah.
Megan Lindenberg, I'm a trauma surgeon at Emmanuel. I've been there about 8 years.
And Dr. Foster?
I'm Dr. Willie Foster. I've been an emergency physician for over 35 years now, the last 17 out at Florence Critical Access Hospital on the coast there, and have been involved for quite a few years with the EMS committee, and then with the STAB, and now with this committee.
Robert and myself have already introduced ourselves, and we have Nellie in the back here, who is assisting us today as well, and Laxmi is also assisting us online.
Do you want me to introduce myself now?
Yes.
Okay. I'm Jeremy Buller. I've been the trauma program coordinator in St. Charles Bend for the last 10 years. Before that, I was an emergency nurse for 15, and been part of ATABs and state meetings, held multiple different positions over the last 10 years, and happy to take the lead on this. And again, bear with me as we fumble through this first one while I get my feet under me.
All right, so we are moving to another room at this time, because there's going to be a joint session over in 1D. Albert will be staying in this room and guarding our possessions so that we can leave our computers and other things here, because we are going to have everyone go and hear the presentation all at once over in 1D. That is a separate login for you guys who are online. So we want to make sure you have time to log into that meeting as well. Okay.
And for those of you online who don't know, on the agenda that was sent out, the Zoom link is actually on there. So refer to that email and you should be able to get into the meeting.
Yes. All right.
Are you?
If you want to go ahead and start, the next thing is the subcommittee summary.
Yeah, the subcommittee, make sure I'm off mute. Yep. The subcommittee summary from the last meeting was emailed out to everyone. Did everyone have a chance to kind of go over that and take a look, and can we review and approve said summary?
Review.
Approve?
Yeah.
Yes.
Approve.
I move to approve.
I was told we don't have to have motions, but maybe I'm mistaken.
Yeah, it's just a sense of the meeting.
Yep. Just a consensus, I think, right?
I was reading these.
I would have.
There
but
was
it
some
turned
procedure.
backwards so that.
So you knew your name, your own name?
Awesome. Okay, so the summary from our Q2 meeting has been approved. And now Madeline is going to discuss the patient definition for trauma as defined in House Bill 4081.
Okay, so I'm going to have to stop sharing for a second and reshare because for whatever reason, it's not catching up with what I have over here. So pardon me for a second.
Wow, that was really loud. It was just against.
So part of our task is to come up with a patient definition for a trauma patient. Hint, it's already in rule, but it is up for discussion. So,
Can you give us an example? Is there a current definition?
yes. So we have our state standards, and that is what is in rule. Let's see if it'll go back. I think it'll be when we go forward. We have our Exhibit 2, which is on the left for our field triage criteria. We have our ACS Gray Book, and we have the National Trauma Data Standard Data Dictionary. Part of our rules when we adopted them, those who labored through the process, was we largely aligned with ACS. We did adopt the field triage criteria with the exceptions that we spelled out abbreviations, and that's just part of, for clarity, getting rid of symbols. Our Exhibit 4 largely aligns with the Gray Book. In our National Trauma Data Standard Dictionary, we do have an Oregon Trauma Data Dictionary. There's a few little caveats in there, but those are kind of our state standards.
So my question is, based on how much leeway on either side if these are coming from the national standard from a trauma patient? Just trying to understand what the ask is, because I think we all know that there are some over and under triage and some problems with these national criteria in general, right? So how much wiggle room do we have in creating this definition of a trauma patient when we are supposed to uphold what the ACS gives us?
Now, if you're an ACS verified facility, then there's no wiggle room, right? You're going to comply with whatever ACS says, but we only have 5 facilities at this time that are ACS verified. Our 2 adult level 1s, our 2 pediatric level 1s, and we have 1 level 2 that are ACS verified. They comply completely with the Gray Book. When we did our rules 3 years ago now, we completed them a little over a year ago, and they go into effect. The new Exhibit 4, which was the Gray Book, goes into effect October 1. We really tried to go through and see what worked for Oregon. We took feedback, we made considerations in modifying for everyone else who's not ACS verified what was in those standards. If we want to change the definition as in rule, it would mean implementing a new rules advisory committee to change that rule.
If we want to change the definition of patient.
A trauma patient.
Just make sure.
If you, and if you were to want to revisit Exhibit 2 or Exhibit 3 or Exhibit 4, those are rules advisory committees. If you remember, we did Exhibit 2 and 3 together. And so we had EMS and hospital trauma programs together for that RAC because of the fact that we were looking at pre-hospital activation and hospital trauma team activation.
Are the exhibits 2, 4, are those addendums to the definition, or are those
mentioned in the rules? Exhibits 2, 3, and 4, and Exhibit 5 are, as well as the Oregon inclusion criteria, are mentioned in the rules. One of the things that we look at with our inclusion criteria, the whole algorithm, is it doesn't include isolated hip fractures, right? But TQIP does. Yeah. And so a lot of our facilities kind of have that. Well, we're including them in our criteria because we are submitting data to TQIP. Something else that can be revisited down the line is if you want to add that to the inclusion criteria document that has the written algorithm and then the diagram algorithm for what gets included in the inclusion criteria in the trauma registry.
I guess when you're looking at the difference between the inclusion criteria for NTDB versus what the state defines as a trauma patient, and there's that disconnect, but in Exhibit 4, we're required to submit to NTDB. So if you're not following those same patient identifications, it leads to a kind of a sticky situation on where you're supposed to follow, and it doesn't give a clear pathway for the hospitals to follow. So if we were to better align or to have the same criteria either as NTDB or to not require that, one or the other. But if you're requiring to have the hospitals submit to NTDB, and then we have to follow that criteria, but then that's not considered the criteria we're following for the state defined criteria for a trauma patient, it kind of gives that mismatch and a misguidance for the hospitals.
And I know some of you are involved in that RAC for Exhibit 4, and there was pushback on just utilizing NTDB, and that's why we changed the language to the Oregon Data Dictionary and the Oregon trauma inclusion criteria, because of what we were hearing from some facilities that were saying that will greatly increase our workload if we have to include everyone from NTDB. And of course, our higher level facilities who are already participating are already doing it. So it wasn't a difference in workload for them. From some of our other facilities, there was quite a bit of feedback in that was advisory committee to take out NTDB from that language.
I totally agree from a perspective of a hospital that would love to have that push to require TQIP, for lack of a better way of saying that. But having that need to go that way or that requirement gives that push for having that hospital backing sometimes. And I know it is extra work and everything, but it's also a better way we can't really benchmark our patients, and that is a requirement again of Exhibit 4 if we are not having the same patients entered into the same fields and looking at the same apples to apples instead of some looking at some patients and not including others. Makes it very difficult.
Just a reminder, if you're not a committee member, to make sure you use the QR code for public comment instead of just posting in the chat. And again, that Exhibit 4 is a minimum standard. So we have facilities that have 3 levels of activation because they're doing something like a head first protocol, ground level falls, head strikes, etc. And so they have a 3rd level of activation that they are utilizing internally. Our standards are a minimum. I guess the question for this committee is, do you want to change the definition of a trauma patient from what it currently says for as it applies to Exhibits 2 and 3 in that definition?
Yeah,
please.
This is Dr. Foster. I just had one question. In those, displays, where does the delayed trauma patient fit in? The one that, gets entered into the trauma system based on the workup in the ED. You weren't thinking they were necessarily a trauma patient, but then you get your x-rays and CT backs and they do become one. Are those going to be included in the definition of a trauma patient, or where does that fit in all of this?
They are if they fit into the Oregon inclusion criteria. Those findings-based activations where we banned a patient, sometimes it may be, quote unquote, a delayed activation that you, based on findings, are going to be bringing in the resources for that patient. Others are, it didn't change our course of action. We already had all those resources. So there are no team activation and they're included in the registry.
Okay.
Discussion about including on our Exhibit 3 findings-based criteria, but in the Rules Advisory Committee, that was not accepted. There was no consensus that they wanted to have findings-based criteria labeled and placed into our Exhibit 3, but they are a lot of what we see in the trauma system is, and again, after we get, like a head first protocol and you find out that you've got to bleed, now you're going to go ahead and ban them and make them a trauma based on those diagnostics.
So does our patient definition need to have a component of the sentence that says or meets the or? If people
Well,
are
also
getting,
there's a document out there that has exclusion criteria for those hips specifically. And so being that the state's calling those exclusion criteria, can we eliminate the exclusion criteria because some of the hospitals are inputting those as inclusion criteria? Does that make sense?
Yeah. The additional discussion that you want to change the definition of a trauma patient. That would be something that you would recommend, because we're not opening a rules advisory committee. We're making a recommendation to the time-sensitive medical emergency advisory committee about what this committee feels about trauma patient definition.
I have a question. Is there any scheduled time frame where these kinds of definitions are reexamined or reconsidered? Is that part of like a cadence that at every whatever 30 or et cetera, or is that just ad hoc if it comes up again in the future?
Very much ad hoc when there is like the update to the field triage, the update to that we went ahead and did our hospital trauma team activation criteria at the same time, as well as Exhibit 4. So usually something has happened, ACS does not, and even before it had been the CDC that had implemented the original or the last rendition of field triage criteria. This current Exhibit 2 came from ACS for the field triage criteria. So, those are usually a 5 to 7-ish year rotation. But like I said, if we find something that's not working in our system, we have the opportunity to change it. And a lot of it was fatigue, as we just finished doing all those racks. And this was like, okay, let's just let it settle for a little bit and see where we're at. But definitely we can go back and visit things, those other pieces of it. But does this capture trauma patient based on pre-hospital and hospital activation criteria?
I mean, for me, I guess there are some subtleties in some of the definitions that maybe I have some thoughts about, but in the bigger picture, the amount of work required is maybe not worth it to worry about some subtle things that one person thinks about since all the work's already gone into it. So it's my thought.
Sometimes if we're too specific, you really handcuff yourself to this very specific definition rather than leaving it kind of broad and saying, we establish this pre-hospital criteria, we establish this hospital criteria. The caveat with both of them is they have the provider discretion in there, that sometimes you get a patient and they may not need anything, but just report from the scene, mechanism of injury, or like, we're going to go ahead and activate a trauma on this until we find out otherwise. So do you think it is too broad, or do you think it will capture what we need at this time?
In my opinion, I think broad is good. I do think looking and making sure that we're not contradicting ourselves in the different definitions that we put out on what a trauma patient is and our different exhibits is important and something that we should look at some point. But I don't know if there are hospitals out there that have just used Oregon criteria and then gone to NTDB and could maybe give some advice of how many patients that changed or what kind of that looked like to know if it, what kind of impact that would have and give some advice on that. That might be able to give some perspective of what that impact would have on some of these hospitals that it would impact.
Jeremy?
Yeah, to answer that question first, it is fairly significant, the amount of people that you put in. The NTDB criteria basically says if they come to the ER, they get discharged, they shouldn't be entered into the system. But if you're not tracking the team activations that get discharged from the hospital, you'll never understand you're under triage or you're over triage. So we include all those, and we probably added another 500 to 600 patients this year by going with the NTDB criteria. Anyway, the other question, going back to the trauma patient, does this definition actually capture the delayed, the no activations, and the retroactive patients?
I don't think it does.
I don't think it does.
This looks, I mean, from what I'm reading, it goes off of your exhibit 2 and 3, which is your activation criteria, but it doesn't really call into effect those patients that just meet that ISS score over 9 that then we get entered because they meet that score, and we ban them because of their collective findings. So I don't know how to capture those in there of those patients that have those injuries that are, collective injuries enough to make them banded later on.
I think part of what that definition says is at any time meets field triage criteria. Or the hospital activation criteria. So that may be, again, the way it's worded, but I think at any time, you didn't know that they had, bilateral humerus fractures or whatever. You didn't, anticipate they were going to crump, and now they're going to be on a vent. And so you may not have activated. It may have been a delayed activation or a no team based on some of those findings. But at any time, did they meet the exhibit 2 or exhibit 3 is another way of looking at it for a lot of those findings based or delayed activations. Do you think that captures it?
But it's a little bit of a reach because all of the criteria are things like suspected spinal cord injury or suspected fracture. Once you know that it's there, you're no longer suspecting.
From a hospital perspective, we look solely to the exhibit for the definition, and so it's a little simpler for us on the EMS side of the house. I can't imagine that we would want, from the EMS perspective, any alterations. That's if you look somewhere else, or have an is this type of patient. So this is helpful.
Discussion around like full trauma team. Was just taking it from the great book, right? Going to put a whole lot more into that and be settled on, let's just go with what the great book has. And again, having the discretionary in there, but there again, after you find out that, yes, indeed, this person is significantly injured, does that still capture that they met the criteria for inclusion?
Like part of the difference is that your activation criteria is what you're not confirmed yet. It's all, again, suspected, like we were saying, and your findings entry criteria is confirmed findings. And so do you have this wording where you have activation criteria and then have something at the end that says, or, has findings that meet an ISS of, or whatever that is that defines out what that an ISS of 9 or above, or whatever that is that would then meet that kind of defined entry.
Mhm.
And again, this is about, as described in Exhibit 2 or in Exhibit 3. It's not even getting into that whole algorithm for the organ trauma registry inclusion criteria. This is just about, did they at any time meet the criteria for 2 or 3? Dr. Lehrfeld was really pushing for findings-based criteria to be in Exhibit 3, but it got shot down. So if you tell him that he won it back, he's going to be like, I knew you needed it. What most people are doing is they're just doing findings-based on their own and including them into the registry because these patients were, had some type of significant injury.
And in the past, the findings base was not a document in Exhibit 3, but it was a reference document, I believe, right? It wasn't a rule, it was just a reference.
I believe it was just, I don't know if it was considerations or whatever at the bottom. I can't remember exactly how it was, but yeah, it was not. And again, how inclusive can you be on those findings base to say, if this is what ends up in a findings base, that means you include it. And again, sometimes that becomes very narrow, too narrow. If you have another findings base that wasn't included in the list, and now it goes back to rule advisory to change it.
I almost don't know if findings based belongs in Exhibit 3 because that's really activation and it's not really what we're talking about. So like Exhibit 2 and 3 are field activation, hospital activation, but you're not activating a team on these people. You're just merely entering them into the trauma system. So it's more of an inclusion on findings versus a activation. So it doesn't really belong in these exhibits, but we have to have like some sort of inclusion criteria for these patients that are included, but they're not activating a team on them.
We need to make sure that all of the patients included in the trauma registry meet the definition of trauma patient. You shouldn't have non-trauma patients in the trauma registry, right? So there are theoretically patients who are coming through this definition and ending up in the registry that are not being captured.
Well, our registry has everyone who got banded. And so if it was a suspected injury that now is ruled out, it's still in our trauma registry for a patient that was a no harm, no foul. But based on suspicion, maybe it's somebody who's, history. You don't know if their altered mental status is due to their striking their head or an underlying comorbidity. And so until you know what the source of that low GCS is, you're going to go ahead and activate because you think they may have, sustained a head injury. But then you find out no altered mental status due to a head injury.
So would there be a possibility, and again, this is just kind of tweaking things a little bit, but the definition of a trauma patient means a person who at any time meets field triage criteria for inclusion in the Oregon trauma system as described in Exhibit 2 or the hospital's activation criteria as set forth by Exhibit 3, or patients that are entered or will be entered into the trauma registry. Or something like that.
I mean, it's a very broad definition, but it does capture every potential trauma patient, including some who aren't real traumas at the end, but we are concerned they could be. I like a broad definition because that's how we think in the emergency department. This could be a trauma patient. Hey, nothing came of it. Okay.
Yeah, and we're putting them in the registry as a retro or a no activation, so that would actually capture those as trauma patients.
That's a broad definition.
So can you, since we will need to be taking this to the TSMEAC, state where that additional language would be in the, if we state it?
Can you say it again, Jeremy? Because you said it so eloquently.
Well, reading the whole definition again, but then including or patients that are or will be entered into the trauma registry. Because if we say they're in the trauma registry, well, we haven't gotten to the quick entry or we haven't gotten them in there yet, but they're still a trauma patient. So it's just somebody that we've identified that's going to go into the registry at some point in time.
So, are you saying that those people were placed, they weren't in Exhibit 2 and it wasn't based on Exhibit 3, and it was based on findings based, it's because they met the inclusion criteria, the Oregon trauma inclusion criteria?
Well, it helps to capture those patients that have had diagnostics that identified that they were a trauma patient after the fact. And so, yes, they would, you know, a humerus and a femur, they're going to fit the Exhibit 2 criteria, but they, for some reason, didn't activate a team on them. So I'm just trying to figure out a way to capture those that will actually fit the definition here, but no team was activated or they were not even caught as a trauma patient in retrospect.
Patients found to meet Oregon trauma inclusion criteria for inclusion in the trauma registry, but we can.
I mean, I think the original at any time meets, because those are going to be the findings-based trauma. But I think just adding that other piece of inclusion in the trauma registry, because again, those of us that do hip fractures, those would actually be included in the rule then.
But in no way are we recommending that all hip fractures be activated as traumas in
No.
the state.
No.
We're not changing the activation criteria. We're just talking about the definition of a trauma patient. Okay. Consensus around that? Anyone else online?
It sounds like there may be a lot of public comment about this.
When we do public comment? Yeah, there's time at the end. I do. Please.
Yeah, I know we've got some time slotted at the end, but we may want more than just 5 minutes just to get some other input to make a good recommendation moving forward.
I'm sorry, guys. Yeah. We've got a whole system down for everybody putting in their public comments, and then you just sort the trauma ones and they pop out to the smart sheet. We do have time now, do you think, Jeremy, to go ahead and if Nellie is able? Yeah. And what we do in public comment is just read your comment.
Yeah, Madeline, I mean, we've got another 20 minutes designated for this. So if we can do just the specific public comments that are related to this definition, I think we've got time to read those and get some more insight before we make a recommendation.
I agree.
1 verbal comment and 2 written comments. So should I just do written or verbal?
Do they put that they want to speak?
Yes.
Okay. Yeah, we'll just take all 3. We can do the 2 written ones.
Okay, so the written one.
You're gonna have to speak.
Okay, I can speak up. I'm just asking you. Okay, so we have 1 written comment from Katie Hennick. The written comment states, I thought the staff had elected to keep the Oregon inclusion criteria the same. I feel we should add that. The second written comment by the same commenter, Katie Hennick, written says, that doesn't include a GLF distal femur fracture, but Oregon inclusion criteria would include it.
Can I just comment? Sorry. It's probably easier to add a verbal comment. Or is that possible?
I don't think she heard you. But Katie?
Sorry, I was on mute. I think that's fine.
I couldn't hear. So, sorry, the last one I was responding to Madeline's example that she had given, but I didn't realize there was going to be such a delay in public comment. So I guess I'd go back to Jeremy's proposal of just adding or included or should be included in the trauma registry.
Thank you.
Public comment, yes, we have one verbal comment, Kathy Tompkins.
Kathy, do you want to speak to your verbal comment?
Yeah, sure. Yeah, so I guess I can just comment from a little historical perspective. Back in the 2016-17 revision of the inclusion criteria, we tried January of 2017, we kind of did a modified entry. We tried including hips. There was a lot of discussion. Hospitals wanted trauma surgeon consults added in order to capture the volume instead of finding some internal processes. I was 10 years ago, I was newer in this role and learning a lot at that time. And we had our recent RAC and we had asked if that inclusion criteria was going to be updated because there's a lot of interpretation on how one person reads a sentence, another will interpret it differently. I would just say personally, not representing my organization, that as a PI trauma individual, it's really hard to do benchmarking when we're all entering things a little differently. And we're required in the Exhibit 4 to submit to NTDB, but then we're not following the same criteria. And I think it would be really helpful, especially for a lot of new coordinators that might be listening to the meeting today, if you were to pull up what the current inclusion criteria is and what the new one would be, and have an understanding of the volume and the workload. And if you decide to move to some similarities with the NTDB inclusion criteria, that perhaps that is done in a stage process over time, because it may take additional workforce and there may be financial impact to organizations, and it would be important to understand that. But I do agree that the definition of trauma patient needs to just include the wording of the inclusion criteria, whatever we end up deciding that should look like. Thank you.
Thank you for your comment, Kathy and Katie, and I believe that is all we have at this time.
There we go. Whew. It's not wanting to advance. Okay, so at this time, the next steps will be to present the patient definition to the time-sensitive medical emergency advisory committee. And they will vote to send the definition to MSAD, or they can request it be brought back to the subcommittee for further discussion and recommendations. You have to remember, next month, the trauma system celebrates 40 years. So a lot of this work and the work that we've been asked to do is because the other committees who are starting from scratch are having to develop those definitions around cardiac patient and stroke patient and everything. We have literature that kind of has helped define that. We have processes that have helped define it, but that would be our next steps. Is Jeremy will be taking our this committee's recommendation to TS and EAC for consideration.
So if we do add to this definition that you currently have up there, does that have to go to a RAC, or is that just a recommendation that we're making to the time sensitive emergency committee and they can adopt it as they choose?
It's a rule change.
Right.
to change that language. Obviously, it's not the same as doing exhibit 2, 3, or 4. But then you have to ask yourself, do you want to change anything else while you're in there? If you're going to convene a RAC, are there other things? But what we're doing is just as a subcommittee making a recommendation to the advisory committee for all time-sensitive medical emergencies on what we think should be changed. And then it will be Oregon Health Authority EMS program to decide on implementation and convening of RAC and that type of thing. But
given that the other groups, STEMI and stroke, will have to convene a RAC because their rules are their language is initial definitions, right? And it would have to be approved. So would this be included in the same RAC, and therefore it's not as big of a lift?
RACs are usually specific to the topic area. And so if it was a stroke RAC, it's going to be very specific about stroke definitions, categorization of hospitals, rules, which accreditation bodies you're going to accept. It's a very different, they would be very much focused. I don't think they would have
individual RACs for each group.
But again, this is, it sounds like, Jeremy, that's the consensus of the committee for you to take that amended definition as a recommendation and for them to send it through the other committees for consideration.
Okay, so I recommend it tomorrow, and then they bring it to the board, and then once they decide that yes, we should make this change, then it goes to OHA. Then you put a RAC together, and then it happens. So I don't think it's going to be a huge lift, because it sounds like from the text and everything I've been getting, it sounds like consensus is this kind of captures all the patients. So I don't think it's going to be too hard to put something together for this. So I will bring the recommendation forward.
And I believe you said tomorrow that TSMEAC is this afternoon.
Correct.
I think it goes there, but I could be wrong. We can get clarification from Stella. I believe it goes to the committee this afternoon. If there is one, the other committees may not have one.
Oh, so I don't need to bring it forward this afternoon then?
I think you do, but I will get clarification on that. But I do think it's for presentation this afternoon.
Okay. Sounds amazing. Any more discussion around this? All right, it looks like we're going to take a 10-minute break, and we'll be back at 10:57.
Even down south, probably our emergencies.
Sorry, Victor.
I'll take responsibility. even though it was Victor's fault.
All right, now looks like it's time for regional roundtables for updates. I guess, do we want to start with ATAB 1?
So we had our meeting on Monday at Columbia Memorial in Astoria. Several people from Portland made the trip out to the coast, which was very nice. We focused on talking about how we can work with data in the future as we come across the state registry transition. We talked about some of our outreach efforts and education with EMS, and we had a robust discussion on mass casualty response on the coast.
Do we have two? We met about a month ago now. For overall a pretty robust discussion. I think we troubleshot a couple of upcoming potential EMS issues, which are they're closing a large bridge in Salem to redo it. So just how we're going to navigate the EMS and triage system around the hospitals that are there.
ODOT actually met with some of the EMS agencies last week. I wasn't actually a part of it because I was out of town, so I'm not sure how that meeting went. But I can reach out and see, but yeah.
I actually, an update on that
Perfect.
is that the bridge will be closed and there will be one-way traffic with a flagger on the bridge to allow any EMS people to come through if they're able. And that's where they stand as of late.
Okay.
They're diverting if you want to go up and around.
Up to Newburgh or Corvallis.
Yep.
Okay.
And to come around. Other things we talked about is essentially looking at our under and over triage to see what
Patterns.
we have throughout ATAB 2 and what we can identify. And then we also discussed transfers and how we can facilitate more transfers coming to Salem Health as the region, the largest center in the region, to mitigate the number of trauma transfers that go up to the level ones. And we're going to look at that data to see what is actually being transferred, to see if our hospital at Salem can offer potential those services there rather than transferring to Portland and saving the level ones for truly those transfers where we don't have the capability to treat.
One thing we're going to start reporting out is the reason any transfers that go out of our ATAB, the reason that they were transferred out, so that we can start looking at that and seeing if there's transfers that we can retain in our region and see how we can help that. And then within Salem, we are working on improving our transfer process for traumas. We have a STEMI bridge line that expedites STEMI transfers, and we're looking at kind of mirroring that process for trauma and are in the process of building that system out within our hospital. And then it require some education and build out. So that's coming, but I don't have a time frame on that. We did have a little tiny mini little MCI in June in Salem, mass stabbing at our homeless shelter, which was a little test of our mass casualty system, and everyone survived and did well. And Alexis was actually our trauma surgeon on that day, and but it did give us an opportunity to kind of test our systems and find some areas that we can improve on in our communication, and which is a great way to kind of improve those areas and in a real life situation. So that was a good learning point for us.
And I think another learning point that we took away from that is that, and Megan, I'm sure you've heard John Van Horn talk about this, is that we stress our mass casualty enactments. We're not stressed enough during that time. And so when you can really see what happens when you do stress the system, even if in a mini mass casualty, and how there's potential to improve on our scenarios when we do it.
Right. Your scenarios, you staff up and you plan, and you plan for your 20-minute notification, and this hit our back door as the first EMS call it coming in, and they were at our back door. So you don't have that time to prep that you planned for, and so it really kind of gives you that perspective of maybe we need to do our mocks a little bit different and not like in the Disneyland version that you play in all the time. So, but it was a good learning opportunity for everybody. So. Yeah.
I think that's good information for everyone, because you don't have the 20 extra staff there when you have the events happen. So how do you stress the system as is? And I think there's some good learning there. Good work. ATAB 3.
Have any particular information? I'm sorry I didn't prep to look at our notes or minutes from the last meeting, so
that's okay.
In particular, I will just make a comment though about mass casualties and doing mock MCI drills. I think that I suspect this is similar across the state, but our emergency department is so overwhelmed and stressed every single day that every single day we're basically, in some version of that. So I think that makes it very difficult to conduct drills that are meaningful because we're always barely surviving on a day-to-day basis. So I think it's a problem as far as the training and learning from those types of events, because it's hard to conduct them in a way that's quite helpful, because when you already have massive weights and overwhelmed lobbies and hallways, it's often difficult to devote any resource to the training part. So I look forward to others maybe coming up with solutions for that training, because right now I think that the efforts are difficult. So.
This is Dr. Foster, and I'd add one thing from our ATAB 3 meetings. We often have some very good, case presentations that bring up a lot of issues about patients being first brought to a 3 or a 4 that in retrospect would have been much better served by going to a level 2, and how long transfers can get delayed when patients stop at a 3 or 4. And it led to some good discussion around that issue.
Yeah, I know that's an issue that we've tackled out here too, or have been attempting to tackle, is trying to figure out, if the patient stops in Prineville, let's say, which is 40-minute drive away, they have to do their note, they have to stabilize the patient before they ship them out and do their medical screening exam and all that kind of stuff. And it typically delays the patient getting to us by an hour. So
an hour would be great. Often we see cases where it's 2 or 3 hours, and it becomes more problematic. Yes.
Yeah. And, the air team is there to take the patient, but the sending facility still wants to, finish their CT scans or whatever. It makes it difficult to get those folks out of there. So that's an issue that we're trying to tackle out here in ATAB 7. Anyone on from ATAB 5? I know that's Matt's region. ATAB 6? Anyone? Well, I kind of gave you an update on ATAB 7. Looking at the list of things that we can discuss, we are dealing with the agency transport issues. Hospital acceptance has not really been an issue at all for us, being the referral center here for our island out here in Central Oregon. We typically will just accept the patient and manage for the most part. There are some unique situations where it's not likely, but for the most part, I think we do a pretty good job. Our outreach has kind of stopped and is going to start up again now that our survey is over. So that's kind of an update for us. Yeah, we do some case reviews and stuff too, and find some good learning opportunities, including our EMS partners in those case reviews to learn. So anyway, ATAB 9.
Hey, this is Anna. No real updates from ATAB 9. The April meeting was canceled, and we look forward to our meeting coming up on the 28th.
Awesome. Does anybody have anything else that you want to talk about as far as unique opportunities that we can all learn from? All right. Well, Albert, it looks like you're up.
Do you want to hear anything from our air medical?
Oh yeah, Victor, go ahead.
Yeah, gosh. From a statewide perspective, I think I could share, like, on the Mercy Flights side, on the southern end of the state, they've been able to stand up an additional helicopter to improve transport services, and Reach MedTrans was able to add additional aircraft this summer to Klamath Falls, so that's improved regional response significantly. Yeah, I can't think of any other significant state improvements.
Adding the heli down to K Falls again, even though it's only a 12-hour service, it's being utilized quite efficiently.
Well, and I think at Good Shepherd in Hermiston, they're building a Life Flight hangar there on campus, which will impact in a positive way that part of the state, and especially for those long transport times.
Yeah, that helicopter is there existing. It's just operating from the airport, and yeah, we're building a hangar on the hospital property, and we're excited to be able to move in and not have that little 10-minute delay over to the campus or whatever that looks like. So that'll be a big improvement. Thank you.
Awesome. And Madeline, do you want to update us on anything OHA related?
Oh, still actively doing virtual surveys. I will say we have a new facility that is Providence Seaside. We're going to be doing their initial survey August 27th, and that will be an on-site. So this is an initial. We're going to go kick the tires and look at their program, because it's been a while since we've had a new application for a trauma hospital. There's another one down south that's talking about it. We know that every facility can bring a value to the community. So as long as they can stand up the resources, that's the most important thing. I am seeing some transitions right now. We've had this period of stability in a lot of surveys. I mean, from 2021 to now, I've seen stabilization in staffing and leadership, some things like that. But there's still a little bit of instability. Sure, see a whole lot less use of travelers, which I know has got to be a huge load off of trauma program managers who are in a constant educational orientation cycle with having to train staff. So, so from my standpoint, I see a lot of stabilization. I've seen a lot of good surveys. The utilization of Smartsheet has had positive feedback, that it's an easier process than SharePoint for uploading all your survey documents, and the surveyors like it. I think the facilities like it from a standpoint of not having to try to embed things into an Excel sheet. It's a easier process, I hope, for folks.
Way easier. I do have a question, because something came up at our Region 7 Healthcare Coalition the other day that kind of made me ponder a little bit, and I hadn't heard that this was an issue, and I'm just curious if maybe it is, because anecdotally, this person seemed to think that it was a problem happening throughout the state. And that was one of our volunteer agencies trying to recruit a medical director for their EMS team, and they are really struggling to try and find someone. Has that been an issue for anyone else?
I haven't heard of any issues.
Okay.
I have heard of issues with getting someone else to step up to be the trauma medical director for the program, and some issues around that as far as being able to stand up a program with having someone who'll be a dedicated trauma medical director. So I have seen anecdotally a couple of those, but some of those discussions even leading to discussions about having to step down a level in designation based on not being able to have the appropriate medical director. So, yeah.
Okay. Well, thank you. Appreciate that. Albert, we'll let you go now.
Am I sharing screen for you?
My thing should be embedded.
Okay.
Oh, not, I can. Yeah, it is. Perfect. So hello everyone, my name is Albert, again, the research analyst for the EMS program, working in the data team. And today I'm gonna give you guys just an initial Presentation on the Organ Trauma Registry Annual Report for 2025. So just some current highlights. We're seeing continued growth in volume across the state, but as we will see, there are differences based on population and spatial demographics. We are seeing improvements in the timeliness of records completed, but also we're seeing an increase in missing data for required data elements, like the activation level and patient demographics. Overall, there's been some big improvements since we did the last report in 2023. So we'll kind of get into just some different things in that aspect. It's in progress. I don't know if you see, I put in progress because it's not officially done yet and we haven't published it. So the quick disclaimer is that the numbers are still preliminary and we're still in final review. So the edits that you see in the final report, or the numbers and graphs you see today, might be a little bit different in the published report just because we still need to fully clean and validate the data, but this is where it's at right now. So here are the counts for records by hospital level. So this is per level in the state for 2023, 2024. As we can see, level 1 and level 2 had greater volumes in 2024 compared to 2023, while level 3 and level 4 both saw a decrease in volume from 23 and 24. But overall, there was an increase in record volume from year 2023 to year 24.
Can I ask a question on that? Does the decrease in the level 3 and level 4, well, it's 23 to 24. I'm wondering if there's correlation between the changes to the trauma criteria, or this would have been before that, I guess. Yeah. Thank you. Sure.
Yeah, this was so in the report, I'm kind of trying to do some further analysis of maybe historical context or why those numbers did increase. There's a couple of ideas I have, but I didn't want to talk about them because I'm not 100% on them. So I just wanted to present the numbers rather.
So it would be interesting though if we broke these down into region, because I have a feeling the siphoning of patients from different hospitals, of how patients are triaged and where EMS is going, plays a role to the decrease in the
3s and 4s and increase in 2s.
who is acquired with hospital, because I have a feeling there's a bypass
The hospital system.
systems. Yeah.
Yeah, in the final report, I do have it broken down by level, by region, or ATAB region.
Perfect.
Yeah.
So you guys will be able to see that. Again, I just didn't include it here because I'm still working on it. But we will have by level, by ATAB for the year, and percent changes for the years as well.
Cool. Sounds great. Thank you.
So this is just some reported costs. So financial charges by trauma center level indicate high fluctuation in costs reported year to year. As we all know, costs reported in trauma records vary widely from level to level and from year to year. I attached the numbers from the last annual report. I know it's a little bit small there, but our 2023 report included 2019 and 2020 data. So I attached that in the top just so you can kind of see the cost variation in a longer period of time from 2019 to 2024. But the bigger table on the bottom is the current numbers, costs by level.
Albert, can I ask a question?
Yes.
Why did you select the 2019 and 2020 data?
So some context, the last time this Organ Trauma Registry biennial report was put out was 2023. And or whatever, that was before I started this position. That report had 2019 and 2020 data. And then, as you guys probably know as well, I think there was a little bit of vacancy in my position here. So when I started, I'm doing the most recent report, which is 23 and 24. But then I'm also going to have to go back and do a 21, 22 report as well. But I figured it'd be more valuable to give you guys the most current report and then backdate when I have the time to do 21 and 22. So you're going to be getting 2 reports, but right now it's the most recent one. Does that kind of answer your question?
Yeah, no, I found it interesting that 2020 was the COVID year. That's why the numbers are all wacky.
Yeah, and I think we're gonna get some good valuable insight out of like 21 and 22, which is it's definitely high on my priority, but I think the most current one is more important right now. So, yeah. So when you
Yeah,
see 20,
let's get the registry working first.
exactly. But yeah, so I mean, something else I wanted to note too is that in the report, I think something we're gonna look at is just like a cost per patient, just to see by level too if there's any valuable information we can get out of that. So I'm looking to kind of trying to find those numbers if I can. Yeah, next slide, please. So just some overall insights that I've found. I didn't really want to include all the tables that I have for it, but another quick note. I was writing this report while we were still talking about REMSAP, so it's ATAB transitioned in timing for the submitting the slides. But ATAB 3, 7, and 9 had larger increases in record volume than other regions. ATAB 5, level 2 had the largest increase in record volume. Statewide, as we've seen on the first slide, level 1, level 2 hospitals have overall increases in record volume. Statewide, 3s and 4s had decreases in record volume. Overall, statewide pediatric patients are lower. Geriatric patients continue to increase, with ATABs 5 and 9 seeing the largest increase in geriatric trauma patients. And final reports will include race and ethnicity demographics for some of these breakdowns by ATAB and level as well. So next I'm going to shift over from record and patient volume to OTR record completion timeliness. So the plots that we're seeing on the screen are a month by month percentage of OTR records completed within the 60-day threshold. It's very hard to see, but there is a percentage goal. It's by a blue line, which is 80%. So anything above 80% is what we want to see. So as we can see from 2023, started the year off strong, then it dipped a little bit June, July, August, but then we kind of recovered towards the end of the year. And we had a similar pattern statewide for 2024. Strong start, summer months kind of dip, but then we recover towards the end of the year. But all in all, I mean, it's looking really good. You want to go to the next slide? This is what it looked like in the last report. So you can see that 80% goal from more clearly because we were falling under it year over year. If you want to go back to the current numbers now, it's a major difference. And we're really appreciative of everyone and all the facilities, all the trainings and whatever people were participating in any efforts to make this happen, because you can see a significant increase.
What's that attributed to, do you think? Such a significant change?
I know for one, I mean, I can't speak on it too much, but there was some initiatives, I think, internally in the state to help with that. But I can't pinpoint exactly like why myself, because I don't have too much historical context. If anyone online or in the group here does, that'd be great.
Well, I think what's interesting is if you look at the new one, it shows the heavy trauma season is showing, it takes longer to get them because there's more patients. And then in the other one in 2020, I think, it shows it kind of almost opposite, that they're getting done more in the summer months, which I found quite interesting when I looked at this.
Was the staff getting pulled to help with COVID things?
You wonder about staff attrition, losses during that period of time, and how long it impacted everyone. Because registrars don't go on trees, and so you lose a significant registrar, and it can really impact everything playing catch up and affect your numbers.
Oh, you're preaching to the choir.
So this is the record completion timeliness laid out by level year over year. So data shows consistent ongoing improvement in record timeliness for all hospital levels, current struggles in 2, 3, and 4. Similar to what I've been doing, I attached the table from the last report versus the most updated one. And we can see, level 1, from 2023-24, we had about a 15% increase. Level 2, a drop about 14%, and then level 3 and level 4, modest, 3 and 1% declines. But overall, everyone statewide, it's still moving that threshold of 80% across the board. Yes. So next I'm going to kind of switch into some injury grouping mechanisms. So the left table is from the last report. The right table is the most recent. And as we can see, fall, motor vehicles, and struck by are still in the top 3. For this most recent report, we had about a 4.7 increase in fall injuries, a 21.8% increase in motor vehicle, and 2.9 in struck. I don't have too many ideas of how I want to go further into this, so I did want to see if anyone had any insight, if there's anything valuable that we could maybe look into further. Because that's also what I wanted to get out of this presentation is, if you guys have any insights or thoughts or feedback for the report, because like I said, it still is in progress. So I'm open to any discussion.
How far back do you have the data that's easily accessible? For example, the summary here, like the fall information, we have it there for those 4 years. Does it go back significant? Is it easily accessible going backwards, or is it not?
I think.
Or do you have to calculate, or is it already computed if there's a number waiting there?
I would have to do some pulling it, but I think 2017 is easy. Anything further than that, it can be done.
I think it's interesting to see changes over time, and in the graph you could see that if there are items there that are maybe more preventable.
So essentially just saying
over the course of time
falls statewide per year.
Right, just looking at those categories, firearms, for example, it's interesting to see a year-to-year difference, but it'd be interesting to see over a longer time frame to really understand if there is a trend or if it's a simple, just statistically, some of these are going to vary year to year, like a firearm injury is going to vary year to year, but if over the course of 10 years, is it?
So if I look at this from my injury prevention hat, right, I'm looking at this as a state, but when I really think about it, it would be more interesting to look at it as a county or even an ATAB region, because then you know exactly what you want to target for that particular intervention. So this is great that it's telling me this, but if you're telling me there's more falls in ATAB 9, then do we need to look and see what maybe, I would say, let's look at the group down in Eugene. Jim Cole's done great things with falls down there. Do we need to share some of what he's done with ATAB 9? So what I'd like to see is where the changes have been and if there's a trend that we need to focus on injury prevention in that ATAB.
Are they similar increases across all ATABs, or are there some that are outliers?
And whether
or
that's
there's some ATABs that have their firearms are super high or their MVCs are super high versus others, so that we know who needs to kind of focus on what type of
injury prevention.
I'd also add that motor vehicle accident specific often is correlated with population growth.
Mm-hmm.
And so if that 21.8% increase, if that's in for example, Marion County's had a significant increase in population over the last few years. If that was the focus of that growth, then we could say, oh, well, it's likely correlated to the amount of people that now live in that area.
But we can also then look back at our data and say, hey, is there a specific road or roundabout, which we know there's a couple particular ones, do we need to bring this to the attention of someone? And so we can we can kind of pinpoint more of that. And I think state data is great, but we really need to suss it out because we have so many different kind of regional areas in Oregon, and there's something different for every region. We're not just this homogeneous state.
Like in Anna's region, it would be crazy if there was a 20% increase in motor vehicle accidents. There's not a population there, right? Necessarily. Something would be going on. Right?
That's great, because that's kind of information that Albert can think about and like, okay, next time I'm gonna make sure, like I'm gonna break these cities down by ATAB. So you have those reports, because it's one of the things that I think we talked about even at the last one. You can't see other people's data. We can, and we can, protected with no PHI, but at least develop some of those reports to where you do know specifically this is where you're at, and things to go back to your ATAB or your SAB or whatever. So I really like that.
Yeah, it'd be interesting to break it down by ATAB and by levels, just to see if the level 4s and 3s are getting bypassed from some of these motor vehicle crashes too.
Yeah, one thing I'll add too is that another project I'm also working on is bringing back like ATAB specific trauma registry reports. So I'm working on building those. So hopefully in the near future, I'll be presenting like stuff like this in each ATAB. Definitely not there yet, but it will be. So just wanted.
Few other things like.
But that is in the works. So next, we'll be looking at the intent of injury. So top table, previous report, bigger table, the current report. So there was an increase in unintentional from 2023 to 2024. We had a decrease in assault from 23 to 24, and a decrease in self-inflicted from 23 to 24. Yeah, I mean, unintentional 5.5%, assaults down 8.5, self-inflicted are down 2.4.
What's the difference between undetermined and other?
Yeah, what's undetermined?
I think there isn't.
It's what happens when you give someone the opportunity to check another box.
Yeah.
When you're trying to do data, anytime you have other, it's awful, right? Because you're trying to like have that so you can have clean, clear categories, which is interesting that there were that many of them in those two categories. So not as much as the others, but.
Yeah. So next, just looking at trauma activation. So for trauma team responses, again, with increase in volumes, as I established in the beginning, we expect to see an increase in the counts of team activations. Specifically, I want to look at the missing numbers from 2023 and 2024, which are highlighted with the circle. Just key takeaway, there's a steady increase in missing information in the required field. And this was kind of apparent also in the previous report. So just using this information to maybe inform the data quality improvement projects, which have kind of been underway and will be underway in the coming months. Yeah. So then the last couple of slides, I just wanted to show you guys some deaths by injury mechanism for pediatric, adult, and geriatric. So for the adult and geriatric, I include percent changes, but for pediatric, since it's such small numbers, I didn't think putting a percent change would be significant. But we can see that there was a small increase of firearm deaths from 1 to 3, motor vehicles consistent 3 and 3, other transport other specified, free, stagnant, unspecified went down, natural environment went down. Struck by or against also went down. Same for adults. Firearm injuries has gone down 23%, 78 to 60. Falls 57 to 58, 1.8. Motor vehicle gone up 17.5 from 80 in 2023 to 94 in 2024. Those are the top three. And then for geriatric, deaths due to falls and motor vehicle have increased, while deaths due to firearm has decreased. For falls, we went from 310 to 333 with a 7.4% increase. Motor vehicles went from 52 to 76 with a 46.2% increase. Firearms down from 15 to 14, 6.7% decrease. And for these deaths by injury mechanisms, I want to do some further analysis and graphs in the actual report. So I'll be looking at maybe any possible trends for the 2025 report, the fully published report. But for now, I just wanted to show at least the data and the what it counts.
Why is there a negative on claim?
What was that?
So there's a negative 1% on fire and flame.
That went from 1 to 0.
But I trouble believing 0.
I mean, as good as the data that gets documented.
0 geriatric patients that made it to a hospital. That documented that way, yeah.
Yeah, I'm just saying,
Yeah.
I find that very, I think to your point, that it's not being documented, I think. So, something.
Well, and to be fair, the state told us years ago that they didn't want burn patients in the registry.
Got it. That makes more sense there.
Yeah, I think so. Yeah, so if anyone has any questions or any discussion,
There was something in the chart, but it's not.
If you,
Go ahead.
sorry, just a reminder to use the QR code for public comment. If you want to make a comment or ask a question, please.
I'm curious, the other transport went, I think it went way down in 2024, if I'm not mistaken. Not the geriatric deaths, just the mechanism of injury. And I was looking at that and I was thinking, why did it go down so much? And it's because they actually came up with E-codes for e-bikes in 2024.
Yeah.
Yeah, it went down 600. I just thought that was interesting that just one E-code can change data so quickly. Awesome. Does anybody have any questions for Albert?
Of course. Like I said, this is all preliminary. I want to just kind of show you guys numbers that I have currently. Hoping to have that report done really soon. I think the biggest thing from it actually being accessible to you guys would just be the publishing process. Once I do it, we have to submit it through a state publishing process, and sometimes I've heard that can be a long or short process depending on how it goes. So I'll have it done soon. I'll submit it to publishing, and then once we get approval, the full report will be out with, which is the 2025 report, which includes 2023 and 2024, the Oregon Trauma Registry. And if you have any further questions or comments, feel free to email me about it if you think of something later. But yeah, thank you guys.
Did we have anything
Awesome. Now it looks like we're going to be talking about our board and committee vacancies that we have. or vacancies. I guess we're going through all the committees, if I'm not mistaken. All right, so it looks like the EMS Advisory Board still needs 2 seats filled. It looks like the rest of them are doing pretty good. Cardiac has some work to do. Stroke has some work to do. And I can give you an update on our trauma subcommittee vacancy that we also have. And I believe we get into more detail in the next slide. Yeah. So these are the people that we're trying to recruit for those subcommittees. So if you know of cardiothoracic surgeon cardiologist, patient advocate educator injury prevention coordinator, or a hospital administrator for the cardiac subcommittee, they're asking us to please help to do some recruiting in those aspects. Same with the stroke, a stroke neurologist, EMS supervising position, and then a patient advocate educator injury prevention coordinator. So our trauma subcommittee rehab specialist was kind of a gray area, and people didn't really understand who qualified to be in that position. But it can be, it sounds like, any kind of rehab specialist. It does not have to be a medical provider. It can be an occupational therapist. It can be a physical therapist. Anyone that specializes in rehabilitation of our trauma patients would qualify for this position, if I'm not mistaken. Stella talked me through it, so I feel like I got it pretty good. And then the EMS Advisory Board, they're looking for an emergency medicine physician, and then a third-party payer of healthcare insurance for the main board. So anyway, if you do know of a rehab specialist that's interested in being on the trauma subcommittee, please submit that or send them the link to the smart sheet. And I don't know if you guys want to drop that link into the chat again, or how you want to go about doing that. I know ATAB 1 and I think 3 are fairly well represented. So we're looking for more of a, maybe a 5, a 7, or a 9, maybe even a 6, because I don't think there's much for the 6 on there. So those would be the ideal places to get a broader statewide representation on the board, or the subcommittee, sorry. Anybody have any questions about those? And it looks like we're ahead of schedule, so do we have any other public comment?
Public comment at this time.
No public comment at this time.
Okay. And do we have a liaison report? Is there a liaison there? So key decisions made. It sounds like we are making a recommendation to change the trauma patient definition. And I guess that action item goes to me to bring forward to someone. It doesn't sound like we've created any projects or tasks that I am aware of. Do we need a board input on any other issues besides the patient definition at this time? Doesn't sound like we need any resources besides maybe a RAC put together once that gets approved to change the definition. And I'll bring the recommendation to the board. So that should cover it. Well, that's, unless there's more PowerPoints, I feel like that's the end of the agenda. We can give you guys all 15 more minutes of lunch. Sounds like they're providing some pretty good lunch for you guys there today. So go and enjoy. And if you're on the next meeting at 1 o'clock, I'll see you there.
There's the QR code for the Q3 updates quarter report.
Do I need to make a motion to adjourn the meeting? Guess not. All right, guys, thanks for coming, and we'll see you next meeting.
So over to you talk about